Familial small intestine NETs, when screening relatives matters. Hello, this professionally resourced, evidence-based content is created by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has a small intestine neuroendocrine tumor, especially if there's a family history, you're in the right place. I know that when you hear about a rare tumor running in families, it can feel overwhelming and even frightening. But today, we're going to cut through the uncertainty with facts. By the end, you'll understand what makes familial small intestine NETs different from sporadic cases, why screening your relatives matters, and exactly what steps you should take next. Before we dive into the familial aspect, let's quickly establish what we're dealing with. Small intestine neuroendocrine tumors, SI NETs for short, are rare malignancies that arise from hormone-producing cells in your small bowel, most commonly in the ileum. Now, what does this look like in real terms? These tumors are often slow-growing and subtle. Most people have no symptoms until the disease is fairly advanced, or they're discovered incidentally during imaging or endoscopy for something completely unrelated. About 30% of patients do experience carcinoid syndrome, that's flushing, diarrhea, and heart-related symptoms from hormones the tumor releases. Why does this matter to you personally? Because these tumors are gradually increasing in incidence, and early detection through family screening can make a profound difference to outcomes. Here's where it gets interesting. There is emerging evidence that small intestine NETs can run in families in a way that's completely separate from the well-known genetic syndromes like MEN1. Now, what does this actually mean? Research has documented rare familial clustering of these tumors. In a 2016 study on prospective evaluation and treatment of familial carcinoid small intestine NETs, researchers found patients with a family history who presented very differently from those with MEN1 syndrome. Let me be clear about something important. We're not talking about MEN1 here, which affects multiple hormone-producing glands, including the pancreas, parathyroid, and pituitary. Familial SI NETs appear to be a distinct entity where the clustering specifically involves small bowel tumors, often without the other features of MEN1. The genetic background of this familial subgroup is still not fully identified. Further research is needed to clarify the exact mutations responsible. If you're supporting someone through this, understand that this lack of a clear genetic marker doesn't mean the family history isn't real or important. It just means we're still working to understand the mechanism. When small intestine NETs occur in families, there's evidence they tend to appear at younger ages compared to sporadic cases. This matters because typical sporadic SI NETs are usually diagnosed in people in their 50s and 60s. In familial cases, occult lesions can be detected early, with aggressive screening among patients with a family history. Now, what does this look like in practical terms? If your sibling or parent was diagnosed with a small intestine NET in their 40s, your own risk window may start earlier than the general population. This is where surveillance becomes crucial. The data reveals that among patients with a family history who underwent screening, more than 80% had multifocal disease, and 1/3 presented at stage 3 disease, even with screening. Here's something that might surprise you. Nearly half of patients with SI NETs smaller than 10 millimeters already show lymph node metastases. This underscores why even small tumors discovered through family screening need to be taken seriously. If this applies to you because you have a first-degree relative with SI NET, this is something to discuss with your doctor about starting surveillance earlier than standard recommendations. One of the hallmarks of familial SI NETs is the tendency toward multiple primary tumors. Research consistently shows that multifocal SI NETs occur in around 20% to 30% of all patients generally, but this rate appears even higher in familial cases. What we're talking about here is not metastatic spread from one tumor, but truly separate, independent tumors arising simultaneously in different parts of the small intestine. During surgery, meticulous intraoperative exploration and bidigital palpation of the entire jejunum and ileum are superior to all imaging modalities for detecting these multiple lesions. You can do the math here. If imaging misses some tumors and your surgical team doesn't examine the whole small bowel during operation, you might be left with undetected disease. For families affected by this, it's essential to know that even after successful surgery for one tumor, continued surveillance is necessary because new primaries can develop over time. If you're supporting someone through this, recognize that the journey doesn't end with one operation. It requires long-term vigilance. This is when screening becomes crucial. If you have a first-degree relative that's a parent, sibling, or child with a small intestine NET, you may benefit from surveillance even if you have no symptoms. The data shows that occult lesions can be detected early with aggressive screening among patients with a family history. Now, what does aggressive screening actually involve? It includes high-quality imaging with CT or MRI enteroclysis to visualize the small bowel, and potentially functional imaging with gallium-68 somatostatin receptor PET-CT scans, which light up these hormone-producing tumors. Some centers also use capsule endoscopy. The exact protocol should be individualized based on your specific family history and risk factors. Here's the reality check you need. SI NETs are usually small and located in a part of the gut that's difficult to examine, the ileum. They're often discovered only when mesenteric lymph node or liver metastases appear on imaging. But with family screening, we can potentially catch them earlier before that happens. The timeline for when to start screening isn't definitively established yet, but many experts suggest beginning surveillance in your 30s or 40s if there's a strong family history. This is a nuanced but important distinction. Some people develop multiple signet tumors without any family history. This is called sporadic multifocal disease. The key difference with familial cases is, of course, the family history, and potentially the age of onset. But here's where it gets complex. The tumors themselves look very similar under the microscope. From a molecular point of view, relatively few genetic alterations are found in signets generally. About 50% to 78% show loss of chromosome 18, and about 10% have mutations in the CDKN1B gene. However, these changes are seen in both familial and sporadic cases, so they don't help us distinguish between the two. There's also mention in the literature of a MUTYH germline mutation being associated with small intestinal nets, though more research is needed. For clinicians evaluating you, the critical factors are: do you have a first-degree relative with signet? Did your tumors appear at a younger age? Are there multiple primary tumors? These clinical features, rather than specific genetic markers, at present help distinguish familial clustering from sporadic disease. If you're worried about someone you love, the absence of a definitive genetic test doesn't mean surveillance isn't worthwhile. Family history alone is a powerful risk factor. Given the rarity and incomplete understanding of familial signets, germline testing that's looking at the DNA you inherited is still evolving. Unlike pancreatic nets, where approximately 17% are inherited and linked to well-defined syndromes like MEN1, MEN4, NF1, or tuberous sclerosis, the genetic basis for familial signets remains largely unknown. Currently, if you present with a signet and a family history, genetic counseling is recommended. Testing might include sequencing for known net-associated genes, though a negative result doesn't rule out familial predisposition. The relevance of DNA damage repair gene mutations, observed in up to 10% of apparently sporadic pan-net patients, is not yet clear for signets specifically. Here's what this means in daily decision-making. If genetic testing doesn't reveal a known mutation, it doesn't mean you or your relatives aren't at risk. Clinical vigilance and screening based on family history remain important. Think of genetic testing as an additional tool, not the whole picture. So here's your bottom line. Let's talk about the 3 categories of action you can take. First, document your family medical history thoroughly. Speak with relatives. Note who had which cancers at what age, and bring this information to your doctor. This is the foundation of risk assessment. Second, if you're a first-degree relative of someone with signet, request a consultation with a gastroenterologist or an endocrinologist specializing in neuroendocrine tumors. Don't wait for symptoms. Early detection relies on proactive screening. Third, if you're the patient, ensure you're being managed at a specialized center with experience in neuroendocrine tumors. The European Neuroendocrine Tumor Society recommends referral to ENETS Centers of Excellence or Centers of High Expertise. These centers have multidisciplinary teams familiar with the nuances of familial disease. Ask specifically, given my family history, what is my personal risk of developing a small intestine net, and when should I start surveillance? Push for concrete numbers and timelines if available. Ask, what imaging modalities are most appropriate for screening in my case? Should I have CT enterography, MRI, or functional imaging with gallium-68 PET scans? Ask, if a tumor is found, how likely is it to be multifocal, and what does that mean for surgical planning? You want your surgical team to be aware they need to examine your entire small bowel during any operation. Ask, should my siblings or children also be screened, and if so, at what age should they start? This question extends protection to the whole family. Seek immediate medical attention if you develop symptoms like persistent diarrhea, flushing episodes, abdominal pain, or unexplained weight loss, especially with a family history. Even without symptoms, seek specialist evaluation if you're a first-degree relative of someone diagnosed with signet before age 50, or if multiple family members have been affected. If you've already been diagnosed, ensure you're seeing a multidisciplinary team that includes surgical oncology, medical oncology, radiology, and pathology expertise in neuroendocrine tumors. This comprehensive approach is essential for optimal outcomes. Let me quickly recap. Familial small intestine nets represent a distinct pattern of disease clustering, separate from MEN1, with earlier onset and higher rates of multiple tumors. Your next step, if you have a family history, is to schedule a consultation with a neuroendocrine tumor specialist to discuss personalized screening. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.